Hello, my name is David Trimberger, and this is my instructor attempt for direct adult orotracheal intubation as well as trauma orotracheal intubation. The first thing that I want to do is gather up all my materials, such as my laryngoscope. So I want to make sure that my laryngoscope is properly fitting, as well as it turns on. Check it one more time. Okay. Then I also want to make sure that I have a BVM with a mask. I have a properly fitting ET tube with a stylet. So for most adult patients, you want to use about a 6.5 to 7 ET tube. This one's currently an 8, which an 8 can be used for more of your larger type patients. And then for pediatrics, it goes significantly smaller. You also want to make sure that you have capnography, some form of a airway adjunct, and then your rigid tip suction as well as your flexible catheter suction. So after you've gathered up all your materials, I am going to put on proper PPE. And then in an attempt to try and pre-oxygenate my patient, I'm going to go ahead and put him on a high flow nasal cannula. Okay. And then I'm also going to manually open up the airway, see if there's any secretions. If there are secretions, then I'm going to take my rigid tip catheter, insert, cover the suction port, suction for no longer than 10 seconds, and then on my way out, only suction on my way out, reevaluate the airway, make sure that the airway is clear, and then after I have determined that, I will take my OPA and I am going to measure, make sure that it is a properly fitting OPA. Then I will take my BVM, attach it to oxygen. I will attach my patient to an SpO2 monitor. And then I'm going to ventilate my patient at a rate of 10 to 12 times a minute, evaluating for adequate chest rise and fall. And then once I notice that my patient is beginning to have an SpO2 above 94% and they have had enough time to be able to be properly pre-oxygenated, I will get ready for my intubation attempt. I'm going to make sure that my ET tube's nearby me, and then I'm going to hold my laryngoscope in my non-dominant hand. I'm going to displace the tongue and then lift up the mandible. Insert my ET tube, inflate my cuff, remove the syringe, remove my stylet, attach them to the tubing, make sure that they are getting adequate ventilations. And then I don't know if I mentioned this earlier, but I would want to go ahead and also put my patient in the proper position of a sniffing position, trying to make sure that I can keep their trachea as straight as possible. So I would make sure that I have confirmation. I would continue to ventilate my patient, and then I could also come over and auscultate over both the lungs as well as the epigastrum for proper placement as well as ventilation, and I can adjust the tube according to what I am discovering. I can also put on a capnometry, plug that into my monitor, and continue to ventilate my patient. Once I see that I am getting proper capnography, I was able to listen for ventilation in the lungs, not in the epigastrum, I will go ahead and secure my tubing. And then I will continue to monitor my patient for any signs of hypoxia. I will watch over capno as well as for any signs of hypoxia and evaluate my SpO2 monitor. Say that throughout my route to the hospital, I noticed that there are some secretions that begin to start going into the airway. So what I would want to do is I would want to grab my flexible tip catheter, To begin to suction, I'm going to represent as my stylet as my flexible catheter or suction catheter. I want to go ahead and insert into my ET tube, cover the suction port, and then slowly suction on my way out. I want to reconfirm tube placement and continue to go back and ventilate my patient for 10 to 12 times a minute, noting for signs of hypoxia as well as monitoring their SpO2 and CAP now, and then evaluating for any changes in patient condition. Thank you.